My name is Jameson Stevie. I'm the Executive Director of the Institute for Competitiveness and Prosperity, housed here at the Rotman School. I'd like to welcome you to the Fleck Atrium. We have an exciting topic to discuss this morning. This is our 20th working paper. The ICP and the task force have been in existence since 2001. And here in Roger Martin's last year as the chair of that task force, we've decided to tackle a small issue of healthcare. You'd never know it, but as debate rages around transit and other various issues at the provincial level, there are 42 cents of every dollar being spent on another topic that doesn't seem to be getting a lot of attention. One of the things that we like to do at our institute is bring light to those issues that need the light, and healthcare is definitely one of them. Today we have a unique partnership, and we decided, since we were tackling a new subject, to make sure we teamed up with some experts in the field, and Longwoods Publications have agreed to have one of their notorious, infamous, and legendary breakfasts with the Chiefs along with us as part of our launch. Before I discuss the structure and introduce Roger, I want to thank two people in particular for their help today. Number one is Linda Peterson. Linda is a new researcher with us at the ICP and has helped drive a lot of the research, number one. So she's the stake of this project, and the sizzle is Hamblin Woolley. And Bob Woolley, who is our designer, has made what I think is one of our most attractive and accessible reports. So a big thanks to both of them. Our structure today will be kicking off with a presentation from Roger Martin, followed by a Q&A session led by Anton Hart, and hopefully get some input from the audience. Roger is the Premier's Chair in Productivity and Competitiveness and the Academic Director of the Martin Prosperity Institute here at the Rotman School of Management. From 1998 to 2013, Roger served as the Dean of this fine school. He writes extensively and is a regular contributor to such publications as the Harvard Business Review and others. Most impressively, in 2013, Roger placed third on the Thinkers 50 list, and we're going after number 1 and 2 in the next ranking. A biannual ranking, not that we're competitive, a biannual ranking of the most influential global business thinkers. I think it's impressive and telling that Roger asked us to start looking at healthcare this year from our perspective at the ICP. And without further ado, Roger Martin.
Thanks, Jameson. Thanks, Yvonne. Thanks. Well, thank you very much for the intro, Jameson. Thanks for the partnership with Longwoods, and I would echo my thanks to Linda. Where's Linda, anyway? Linda, there you are. Thanks for taking the leadership, and thanks to all the other ICPers at the back who helped out on this. And again, thanks Gord for your work on making the report readable and hopefully enjoyable. So I'll dive right in. I'm going to go quickly. You've got the full report in your hands. I want to make sure to leave plenty of time to have the conversation with Anton on stage and take questions. So here it is, building better healthcare. What are the policy opportunities for Ontario was the question we asked ourselves, and we wanted to know a couple of things. What drive costs in healthcare in Ontario, and how does the performance of the Ontario healthcare system compare internationally on both the dimensions of efficiency and equity? And this is the first working paper. We're going to try and do 2 or 3 of these before I step down next year, because there's almost an infinite number of topics within the healthcare domain. But this is where we're starting this morning. So, question. How much does healthcare cost, and who pays for it? Well, it costs $80 billion a year in this province, and the public pays for most of it, but not all of it. People tend to think of ours as a entirely public system. It isn't. 32% of it is actually public spending, and if you go to the Ontario part, if you just take that 68% slice and ask what is that? First of all, as Jameson mentioned, it's 42% of the budget. So it is the 800-pound gorilla that is taking the biggest chunk of the budget. You can see it's double now the size of education, for example. And as most of you know, because you're healthcare people here, it has been growing spectacularly quickly, right? So the growth rate of healthcare spending has, since 2004, been faster than the growth in GDP, right? So it's just taking up a bigger part of the economy every year, and it's been growing a hell of a lot faster than government revenue. That's why that 42% is a number that has kept on growing. Now, there's perhaps a happy story at the end where that's ameliorating some, but realize that the vertical axis is growth rate, right? So the growth rate is slowing, but the growth rate is still dramatically higher than either government revenues or GDP, right? So it's still eating a lot. And if you just look back over kind of the last period, essentially the story of the finances of our economy are that we've had the benefit of falling interest rates, right, which has given us this nice bar, this friendly bar here, which is debt charges going down. And basically what we've done is invested the fact that we've had falling interest rate environment into healthcare, right? That's basically the story. One big cost item has fallen, and we're using that to pay for healthcare. Now, I don't know if you guys have noticed how low the interest rate regime is now, but last time I checked, we're not going to have a bar like that anytime soon. In fact, if anything, the bar will be the other direction because they're about as low as they can possibly get. So it is a warning for the future. We've used a one-time benefit of reduced interest costs to invest in ongoing healthcare costs. And here's just a more recent picture. That previous picture was up through 2009. This is recent, and total expenditure per capita and government expenditure per capita has at least ameliorating. It has in most OECD countries too, as governments have figured out that this is eating the entire budget of most OECD countries. Where do our health dollars go? This is just a breakdown of the big section. So hospitals, the biggest chunk at 23 billion, 14 for drugs, 13 for physicians. So drugs, thanks to being up over the last 20 years by 312%, has become number 2 rather than number 3 in this, and physicians have more than doubled over that approximately 20-year period. If we ask what drives health costs, here's a way to look at the drivers. You can determine how much aging statistically costs you, how much population growth costs you, how much inflation in the general economy costs you, and then there's a residual, which is essentially the thing getting more expensive inherently, right? And what you can see is that the hospitals, which is the lowest growth, right, which is consistent with this, right, hospitals are growing 53%, physicians 116, drugs 312. So hospitals growing the least, and you can see population and inflation is the same for everyone. The impact of aging on hospitals, physicians, and drug costs is a little bit different. But what you can see, right, is that in some sense, hospitals have gotten inherently more expensive over the last decade here. This is now 2000 to 2011, right? But not a whole lot. Physicians have gotten way more expensive, right? Way more expensive, and so have drugs over this period. So that's what's driving healthcare costs. Now, in terms of spenders, Ontario is actually quite a big spender in healthcare. So this is all the OECD countries plus we've broken out Ontario, right? So all OECD countries here, and this is expenditure per capita in PPP adjusted dollars, and what you can see is Canada's near the top. Of that, with the king of healthcare spending, the United States of America, in a league by itself, and Ontario is slightly lower than Canada, but essentially compared to all these jurisdictions, many of which along this path, kind of like Denmark, Luxembourg, Sweden, Ireland, Finland, New Zealand, Iceland, etc. Ontario is bigger than. So if you compare it to those countries that are actually bigger than, we are at the top end of the spending. Now, most people think of Canada as being this highly public system. It sort of isn't. I mean, it's actually, if you look at really comparative jurisdictions, both Canada and Ontario, and it's about a wash there, around 70%, but you can see the Netherlands, Germany, France, Sweden, UK, and New Zealand all considerably higher. So we actually don't have that massively a public system. And you can also see that America, which is where it's all private, right, actually spends more than us on public spending on healthcare, right, alone, because their number is so high, and that public share of 49% adds up to more than our 70% of a small number. So the U.S. is actually the king of government spending on healthcare, if you look at it this way. And if you just look at sort of efficiency of what we do, one driver of healthcare costs, right, is supposed to be how old your population is. And so this is along here the percentage of the population that is older than 65. And so you can see some countries, right, famously Japan is almost a quarter of people over 65. Now they've got the most challenging demographic situation in the world, will for 30 or 40 years, until China will have the most challenging in the world. But what you can see is that we're sort of kind of average on our population over 65, and we're above average in per capita spending in this pattern. If we ask just sort of what's the kind of performance against international averages on a bunch of factors, what you can see is a few things that are kind of strikingly kind of bad about Ontario. So that, I mean, the good news is perceived health status is exemplary, as is care coordination. So those two are nice, but the access to healthcare after hours, right at the bottom, appointment wait time, right at the bottom. So despite spending a lot, we don't get particularly exemplary results from that spending. So that's sort of just some background, and we from having done this, and there's lots more of the data in your report, but we think that there are 8 policy opportunities for Ontario at this point, if Ontario wants to tackle some of the challenges that have been laid out for healthcare. And these are opportunities. There's things that have to be thought about, but we wanted to put out our views at this point about what could be done. So, strengthen primary care. So, on a number of dimensions, our primary care performance lags international peers, like on wait times and access to after-hour care, delivery of chronic care, use of IT, provision of team-based care. And so, I mean, we really believe that we've got to involve the medical profession in primary care reform if we're going to get the most out of that large expenditure. We've got to do more to measure performance and strengthen our accountability. More data is needed to make sure that we know what our performance is and can improve that performance. And one just an example of stuff that just shouldn't be happening and is expensive and inefficient at the same time would be this. We absolutely win on avoidable ER visits. We're the world leader in avoidable ER visits. So because you can't get an appointment for much of the time with your primary care physician, you show up, or we Ontarians, I should say, show up at ERs, and as you can well imagine, that's not the cheapest way to get taken care of. And so we have a 50% rate of avoidable emergency room visits, which is the highest in the world. That's something we should not have, and for sure shouldn't be proud of. I think we've got to engage physicians to be leaders in the change. You know, it's physicians had an important part. We have a unique healthcare system in the sense that that physicians were involved centrally in this as private business people rather than employees of a large healthcare organization. We need to get their help. We should look, even though you know. The debate rages over Obamacare in the U.S. There are some lessons there. Accountable care organizations. We should take those lessons. Why do we believe that physicians have to take leadership in this? It's partially because of this. Right. What we've done is invested massively in physicians in this province over the last decade. Arguably, they're doing the best of anybody in Ontario. Right? It's not been an awesome time, as we know. Right? Lots of people took it in the teeth, you know, in this period here. Not physicians. Physicians' incomes are going up dramatically higher than anybody else in the province, right? And if you ask where is it best to be a physician in this country, there is no question. There is no question where it is best to be a physician in this country, and so I think we simply have to make sure that physician leadership in this province understands what their position is and show leadership in helping us figure out how to take that huge amount. That is an enormous investment in physicians in this province over the last decade. If we don't take advantage of that to make our system more efficient and more effective, we have wasted that money, in my estimation, right? And that is unjustifiable. But I think there's a win-win, right? Which is to make this system kind of work better and overcome some of the challenges that make it less efficient than it could otherwise be. We've got to accelerate deployment of IT in the healthcare sector. Both Canada and Ontario rank lowest in EMR use among international peers. Why? You know, can we be proud of that? I mean, there is no good reason, and few physicians in Canada have access to benchmark data, right? So this is use of electronic medical records. Pretty awesome, huh? I mean, like why? You know, I think we need to use IT to collect the data to make sure we have the highest level of performance. I, for one, by the way, on electronic medical records, buy the argument of a woman named Pat Meredith, who did the big payments task force for Ottawa, who believes that what we've got to do is make your medical records your property, not the medical care system, and have you keep your medical records. There should be a distributed system. The problem we're doing is we're trying to solve this problem with 20th century solutions rather than 21st century solutions, so that we have gigantic databases that can be hacked into, that we have to worry about the security of, that we got to all agree on the same kind of systems. That's all silliness. And the 21st century solution is having legislation that says you own your records, nobody else does. Yours is in your own records. You show up at your provider with your card that enables them to access your own files that has every last thing in it. That would transform the costs of healthcare. We could do it. I don't know why not. It's kind of silliness, I think. Oh, right, and benchmark data, right? So, I mean, why would we want to be proud of that either? Implement Ontario-made pharmacare, so spending on drugs has increased faster than hospitals and physicians, as you've seen. And it turns out Ontario spends more on drugs than other countries and offers less public coverage. Okay, so this again is not something to be particularly proud of. So here this is again the story here, that 312% increase, real increase in spending. So drugs, you know, it's been a transformation of the nature of healthcare over this period. There are absolutely great things about it. So I don't mean to say that this is some kind of a disaster. However, this is a rather telling slide. So Ontario is second top in the world on pharmaceutical spending per capita. Second top in the world. So it's nice, Linda, thank you for putting together stuff like this for me, because I'm no longer dean of the business school, which is good after 15 years, but for the entire 15 years I've been here, each time there's a new president of one of the international pharma companies, they figured out that I do work on competitiveness and that I care about clusters. And so they come to see me and explain to me that the only way that their company can invest in Canada and invest in this province is if we overcome our sort of restrictive policies that don't allow their drugs on the formulary and make Ontario an unattractive place for them to do business. That's 15 years worth of those visits. Linda, where were you 15 years ago? That's what I want to know. Because I didn't know when I was talking to these guys and gals that that's just false. Any guesses as to, in the entire biopharmaceutical industry, all the clusters involved in biopharmaceuticals in Ontario, how many jobs there are? Guesses? 9,800. Do you know how many there are in financial services, just for example? Oh, this is in the GTA. Sorry, not Ontario. There are probably a few more, maybe a couple hundred. 263,000. Very good. That's a very close guess. And you know, biopharmaceuticals, big, important, growing sector, right? Well, it's not. It's little. But it's also shrinking. That job total is lower than it was a decade ago. So I can just declare myself to be closed for business on this argument. Don't come and see me anymore arguing that Ontario is so parsimonious about its spending on drugs in the province that you can't invest at all in this province, and you got to open it up for us. No, we spend the second most in the world, and it's a tiny little industry. I would love it to be bigger. I would love it to be bigger. No question. It's good jobs and everything. I'm glad we have those 9,800 jobs, but seriously, knock it off with that argument would be my view. Spending on drugs is, as you see, grown rapidly. We are the drug spending, capital of the world. So we haven't caught up with the United States yet, but we are briskly moving in the direction of being the #1 drug spending jurisdiction on the face of the planet. That notwithstanding, 1 in 4 Ontarians are uninsured, which is not exactly what we would love to be the case. But we think there's an argument that you know, this ain't working, this ain't working, this ain't working, and this ain't working. Right? What do you think? Right? None of those is it's working chart. And so our view is that we just have to take fairly seriously tossing the system we have now for pharmacare and thinking from first principles. Like if, I would say like if you, so you got these 4 charts. If you were like 3 for 4, you'd say tweak the current system. If you're 2 for 4, you could make an argument maybe you ought to tweak the system. If you're 1 for 4, somebody who really loves the current system might have a chance of making some kind of non-ridiculous argument for it. But I think 0 for 4 means out of here, yes, exactly. You said it better than I did. Okay. Next one, scale up policy focus on end-of-life care. Here I think is a really big opportunity to probably be leaderly in the world, right? I think having the healthcare system that we have would enable Canada to be the first OECD jurisdiction to be really clever about end-of-life care. As we know, it soaks up an enormous amount of the resources for often very little productive outcome for the folks involved in it. And I think we have a system that's designed not for end-of-life care, that when you're at end-of-life care, you get tossed into it. Right? Fair enough. That is sort of the system. And we know that populations in developed countries are aging. There is going to be much more spent on end-of-life care, and there's going to be an enormous amount spent on end-of-life care to the extent, right, that we continue to almost treat it as an afterthought and say, we're going to have this middle-of-life care system we've got a pediatric system, hooray for that. Then we've got the rest of your life other than the end-of-life care, and we throw everybody in end-of-life care into that. Not everybody, but the vast majority. And I just think there's opportunities here to fundamentally rethink this and actually not do the Canadian thing, right, which is to benchmark what's done elsewhere and then do that. Why don't we just forget about that for the moment and just say, it's a problem, it's an issue. Couldn't we think from first principles, and couldn't we design an end-of-health care system that would actually be way more efficient and way more effective in producing outcomes? I mean, we should actually, I think, have more of a debate on what should end-of-life care look like. What are good outcomes for that? Right? I don't think we do. I don't think we do. Introduce a savings plan for pre-funded drugs. So I mean, this is just the way we do drug costs. Like as you notice, drug costs have gotten kind of huge, and we do a sort of a pay-as-you-go thing, unlike CPP, right, where we put money aside for the future. And I just think it's something, given how gigantic drugs have gotten. And again, pharmaceuticals are great. They're making our lives better. And while they're doing that, they're just becoming a bigger chunk of healthcare. It's pretty simple. And so it's one of these things where it's becoming so big, and it's going to get bigger. We should be thinking about what is a sort of sustainable way to handle the financing of pharmaceuticals. And right now we do the traditional way. I'm not nuts ever about the traditional way of anything unless it produces good results. Then when you have a traditional system that produces really crummy results, I'm sort of not into that very much. So we should think about that, I think. Build the case for co-payment. This would be sort of one of the sort of almost I have a dream thing. I mean, it is kind of silly, right, to not have any co-payment at all, and means-tested co-payment. So we're the only OECD country, and I don't mind us being unique, right? That is something, you're being innovative, you're unique. But I'm always interested in having the innovation have a purpose, right? If it's just sort of random, we randomly do something different than other people just because we sort of always have. I'm not so nuts about that. And so I think we should just think about how could we build a case for this. And as our friend Mike Kirby says, if you go back and look at the history of all the way back to Tommy Douglas, he never said ever that it would be free, right? That just wasn't that just wasn't part of it. Somebody along the line said it had to be absolutely free. I don't buy it, because I think there is this big moral hazard problem. Last thing is this is one of these things that exists but doesn't make any sense, because it's regressive and unhelpfully so, which is exempting employer-provided health benefits. That's just expensive, costs us $3.4 billion, and gives a regressive tax break. I wouldn't, right? I just there's no real sense to that, and I think they should not be a tax-free system. And that would give us $3.4 billion to invest in things that are more useful. And I can make up a big long list, and so I'd rather have the $3.4 billion back. So those are the 8. We think the answers aren't absolutely clear in any one of them, but we think that Ontario would have a heck of a lot better healthcare system 10 years out if we started working toward these. And it's possible that you work towards them, and some of them they don't, nothing good happens. We can't figure out something good. Fine, but I think if we worked away at all those 8, we could have a system that is just more sensible, more leading edge, rather than kind of trailing edge. I mean, I love the fact that we took a bold step as a country and said we're going to have this healthcare system that covers everybody, and is not sort of a big institutionalized, but rather it's delivered mainly through private actors. That's cool. I think we can be proud of that, and most Canadians are proud of that. But rather than rest on our laurels of that pride, when we see a lot of things up there that sort of say, to me at least, this is not working awesomely well, why can't we make it better? And hopefully these are a bunch of practical vectors that we could go along toward making it better. So with that, I'd invite my friend Anton up. Where was Anton? He was standing at the back. He's standing at the side now. Come on up, and why don't we have a conversation, and we'll take questions and do whatever you want. Thank you very much.
Thank you, Roger.
Does any of that make sense?
It will in a minute.
Okay.
I have only one question to get it going, because these people, I know, all want to ask you questions. You say, let's put the physician in charge and let's fix the system. You don't really mean that, do you?
I mean, I actually do. For what it's worth, we actually do. I mean, I think I don't think, based on what I've observed over the last decade or 15 years, well, 14 years since I've been working on public policy, is that we've invested enormously in them, and they have to deliver system leadership, and it's the best solution. I don't think going to war with the physicians, which is one approach, is the smartest thing, but sort of leaving it to say, you guys can argue every year for more increases in cost of living and whatever, and result in the kind of charts I've shown, but you don't have to really take responsibility for the overall consequences of that. I just think if we're going to invest like crazy, we need some leadership from them, and I think I don't like the alternative, and that is that we've just got to absolutely, like, there is an alternative, right? The alternative, I think, is to say we're going to get it back to all occupations. Right? There's no reason why you're particularly exemplary over all other health occupations or all occupations. That's what they've been growing at. I mean, the level is enormously higher than all. It's like about 8 times that level, but there's no good reason. There's no good reason for that. So let's go to war. I'm not. I'm a Mennonite. I'm not much into war. I'm sort of into peace.
So a Calvinist and a Mennonite up here, guys.
Yeah.
The reason I raise that, because I'm sure that everybody here and everybody that I know and everybody that you know really like their physician. They're generally really happy with the care they get, and they trust these individuals. But you put them together in a group, and you're right, they're asking for more and more and more and more, and we don't trust them.
Yeah.
So how do we get past the trust?
Well, I mean, that's where I just think in social systems, I think when you don't ask for something, I don't think you get it. And so I don't think we've asked them to take leadership for fixing a system that is heading in a bad direction. And so I think they just default to, okay, well then we're gonna talk about what's good for us. And I don't know. I mean, I don't know if they've do we tell them that and that? Maybe we do. I don't know. I haven't seen these before. Maybe everybody knows them. I didn't know them. And interesting enough, a lot of the work we've done over the last 15 years, when people are not aware of the international comparisons, right? You know, our Ontario government, bless them, had no idea that we graduated 50% of the people from graduate schools per capita as our peer states in the U.S. 50%. When they saw it, they said, well, that's kind of stupid. And spent $700 million in closing that gap. So what I find is that we often and things like that, right? Do people really know that we're amazingly bad on that front, and do people know we're amazingly bad on those fronts? Like I think Ontarians, right? Because there's no cost whatsoever of showing up to the ER, right? They say, well, just the way it is that we can't ever see our doctor when we need them, but that's just the way it is. I won't blame it on the doctor because that's just the way it is. And so I show up at the ER, and the ER, I have to wait around for a while, but the ER takes care of me. And meanwhile, right, the Ontario Treasury, it's like ka-ching, 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 this huge cost that's just been incurred. But that people don't wake up and say, gosh, I should have never gone to the ER. And I know if I did that international benchmarking, the benchmark for your physician being available is there. They don't know that. So part of the job here is to make it more clear to people what trade-offs are being made implicitly and explicitly for them.
So yesterday, I sat in on a presentation you gave on strategy.
Yes, I've been like speechifying all week. That's why I'm hoarse. I'm taking a break tomorrow.
And then some young man stood up and asked you a question about how his very small organization could raise some money. And you just gave me $10,000 worth of advice, as well as the whole audience, I think. In like a quick second, you had your monitor hat on, I think, and you did some consulting.
Yeah. Well,
so if you want to put the physicians
in... You can't teach an old dog new tricks, and I'm an old dog in strategy.
All right, so let's take that talent, and suppose we get all the physicians together. Will you hit it up?
Would I hit it up?
Yeah.
No. No, I'd want somebody who knows a hell of a lot more about the system than I do. I mean, I'd chip in from the side, but I'd volunteer Jameson before I'd volunteer me, because he knows a lot more than I do.
Any other volunteers out there? No? I'm going to go way to the back with the first question. I'm going to bring the mic over there, John, so that everybody can hear you. Oh, no, there's one right behind you. Right behind you.
John Ronson from TELUS. A+ on a spectacular indictment of the current system. I'd say a solid B on your prescriptions. Some of them aren't that original, but that's okay, because I think, sometimes good ideas have been around, but, well packaged. I'd say a D, probably unaddressed, on the change management piece, which is the piece that I get most concerned about, because as you pointed out in a couple of your slides, I mean, we didn't buy change, we we just continue to pay more and more for what's essentially the status quo. So I guess my question is, what gives you confidence on the grade I gave you on the D that what would your confidence first, and then what would your advice be around how we actually drive a change agenda? Because I think you've absolutely nailed the current situation, pretty solid on the prescriptions, but I don't have any confidence, based on what I observe here in Ontario, that we can actually drive a substantive agenda. Your thoughts?
Well, I mean, it's an interesting approach, right, of an intervention, right? So you stand up to say, I'm giving you a D for something you didn't attempt to do. So that makes me very cheery, but I would I think that's, but two things. One is these ideas aren't all new. Absolutely. What the Institute has done for 14 years is attempted to utilize everything that's out there already, add a few things, a few little pieces of research, but that is, like, I mean, my view is that there's much too much of this kind of work, which is that I'm going to ignore everything else because all I care about is my original cool things because I'm so cool. We've never had that for 14 years, and you'll see, we don't cite everybody on a presentation like this, but in the book you'll see citations, 6 Ways to Sunday, where we say thank you to everybody who's gone before us, and standing on shoulders of giants is a better idea than any. So I'll happily take the B if doing that is not something you like. I mean, I do think that this is the opening salvo. We're going to do several papers on this, and I think what we want to start to socialize is a bunch of vectors where we could go down. And then that begs the question: how do you do it? And Anton was sort of going at the how do you do it question too. I think there's a bunch of questions to be answered there, and you know, I guess I'm enough of an old dog at strategy to know that getting the right answer is only a small part of the battle. It's useful. It's better than working hard on change management towards something idiotic, which happens a lot in life. So we feel fairly confident that going down these vectors is good, but there's going to have to be a lot of work to figure out how to make it happen.
Look forward to your future papers.
Thank you.
Thanks very much.
You're welcome.
So Roger, as a media company, we welcome the media to our event, so I'm pleased to say that Teresa asks the first media question.
Okay.
Hi there. I wanted to get your thoughts on the negotiations between the province and the OMA, which have started, and how effective they are in achieving reforms like this. And can you get the doctors to take on the leadership role through those negotiations? And if you could just talk about your hopes for the negotiations.
Yeah. See, I mean, again, I'm so much not an expert on that. I know almost nothing about the nature, what's on the table for the negotiations. So I'm outside it. What I would say is, if it were me, if I were negotiating, I would just show up at those negotiations and say, okay, we got these two, and we got this. That didn't work. Sorry. Let's try and figure out how to solve that. I'm not at all interested in talking about how much more money you want. That's not a subject I'm game to talk about. I'm game to talk about this, and there will be an economic consequence of whatever cool idea we can come up to fix this. But having a negotiation about how we're going to make that blue line even deviate even more from the rest of humanity is not on the table. I don't know. That's what I would do.
The media is always hungry to ask you questions. This, I should tell you, comes from media that represents the unions.
Hi, Roger. A lot of it was interesting, low-hanging fruit. The part that I'm particularly interested in is the pharmacare side. I mean, we've seen Quebec, for example, has gone to 100% universal coverage for pharmacare, but it's very expensive and it's locked in high cost basically by leaving all the private insurance in place. I mean, would you be in favor of moving to more of a publicly administered insurance system for pharmacare in Ontario? Given the fact that the publicly administered plans right now are about 2% administration compared to about 9% in the private sector. Also the fact that a universal single-payer system would also have much greater ability to negotiate drug prices than having a bunch of insurance companies and the government trying to do it simultaneously.
Yeah, the answer is I'm not sure. All I'd say is that this doesn't work. I'd say two things. One, I'll just do, I mean, I shouldn't do this, but I would never benchmark Quebec on anything. Right? That's one of the things that's come out of the 14 years of work on it. Quebec is a very poor jurisdiction because they do many things very badly. And so I wouldn't, the fact that they've got an extremely expensive 100% pharmacare program wouldn't daunt me. I wouldn't say, oh my God, because it happened terribly there, we should stay away. I would just say, you know, figures. And I don't actually, like, I mean, and I wish, since they're so big and so important, I wish they did better on a whole bunch of things, but it's really hard to go and find something to benchmark against and say, across that entire economy, to say, we ought to do that thing too. So I'm just open, again, this is more, that's bad, that doesn't work. Let's figure out something better, and whether it would be private or public, you know, I don't know enough yet to know.
Way at the back of the room, Roger. Can you stand up so people can see?
Michael Ford. If one were to buy into the 8 policy options there, I would argue that more important or upstream of those options is for $54 billion spent by the government or the public spend on it, that is in fact the fuel for all of those 8 mechanisms. Yeah. And so I would make the argument, and I'd love to hear your comment on it, that what really needs to change is the spender prioritization, allocation, and here's the real kicker, incentives to fuel and support those 8 policy options should they decide to do it.
Yeah, so I mean, I buy that. In fact, I mean, I guess I would make some kind of like system dynamic argument that says, is it still on? Okay. That says there's that big number, that whatever 54 billion number here, and arrows that go to this, these 8 things, and arrows that go from them. So I think you have to sort of think of it as a big system. So I think I'm agreeing with you, which is I would say where we are on these 8 things now, make pressure for that number to get bigger, and then because that number is bigger, it takes the pressure off doing anything here, because everybody is sort of just spending the money because somebody delivered another big bushel basket full for them, or wheelbarrow full for them. And so I think the spending and the size of the spending diminishes the desire or felt need for making changes in those, which then creates an easy excuse for the sort of the cost push from haven't done anything on those fronts. So I'd view it as a big system, and we've somehow got to interrupt the system because it isn't working well enough for us.
Way over here, Roger, we have a doc.
Yeah.
Hi, thank you very much for an interesting presentation. It's always good to have the systems analysis, like in this kind of blueprint.
Thank you very much, Kevin.
My question is, again, I think builds on other previous questions, but what kind of framework would drive innovation and sustain that kind of innovation in that system? Michael Porter has written about the value-based healthcare delivery.
I'm going to give you the mic, Will, because I'm sure
talks about disruptive innovations. You've written a lot about design thinking as a strategy to drive that kind of thing. How does that fit with that, and how do we get there?
Yeah, no, it's. I mean, I think there's a certain side of me that says all of them make a difference. I like Mike Porter's analysis that says we've got competition of a sort that doesn't actually drive innovation. We've got to change the nature of competition to be competition, to be able to do things, kind of better and cheaper. And of course, the work I do on design and some of the wonderful work that my colleagues here have done on design, like a Princess Margaret healthcare redoing the chemotherapy delivery kind of system. That tells me that there's a lot of there if we just go at these issues and don't accept the notion that it is the way it is and it cannot be otherwise. And same with Clay, who basically, with his disruptive innovation, says, yeah, there's always a way. That's why, to a certain extent, I mean, in some sense, policy people, I think in general, always want to have a wholesale solution, right? They don't like retail. They like wholesale. Like, can we just pull a big lever here, literally it's a gigantic lever here from the top, and everything will change? I kind of think that it's an attitudinal thing where we just have to keep saying we have to keep disrupting ourselves, redesigning things, figuring out how to drive better competition. And that's why I'm interested in the idea of physicians showing more leadership, to say, we got a problem, this ain't working, it ain't sustainable, no way, and so how do we make it not crash? I think the way we make it crash is that all the physicians in one area, right, say, here's how we do what we do now. Here's the technology we use to do that. If we just said we need to do that for 50% of the all-in cost, how would you do that? And I think actually there are answers. I actually think that virtually anything in the healthcare system that now exists, we could do for 50%. And have the result be better. But it would require taking the kind of perspective that you're suggesting, which is more grassroots than policy. What I think we have to do at the policy level is make the environment for that better. And right now, to the gentleman prior to use a point, so I forgot your name, but the gentleman, if we keep the tap turned on full and keep flooding it with money, there's not going to be that incentive. So it does get back into the first question, right, which is it's a big change management thing, and I think it has to be retail, and it has to be about innovation and design, and we could do wonderful things, and we could absolutely lead the world. Absolutely lead the world. It would be fun. It would be fun for Ontario to lead the world in redesigning and having every doc and every medical person in this province be thinking we should be world leading in figuring out how to do this more effectively and more efficiently. That would be fun.
I'll have to get you to write about that, Roger. I'm going to put this right through the middle, then tell us who you are. Oh, there you go. There's a mic for you. Thanks.
Good morning. My name is Peggy Walsh. I'm with the Ontario Public Health Association. One of the drivers of healthcare costs is related to chronic diseases, and we know many of the risk factors are modifiable. And I'm wondering if you looked at the role that public health can play in as part of those policy options.
Well, I mean, this would be one place where that would support my view of the 50% thing. I think with a bigger investment in public health, right? I think we could obviate the need for a lot of the downstream stuff. So it's a big system that it's been hard to get investment in that realm. I mean, and one of the things that I know, I believe, and we have task force members who really believe it is that mental health is something that I think we we let mental health problems lead to other problems that then end up being super costly, and I think we could do a lot better on that front as well. But it goes back to a lot of this is retail. There'd be a lot of places in the entire healthcare system that would simply have to take the attitude, we can reinvent. It's not working as best it can. Let's reinvent.
So could you forward that mic? No, there we go.
Thank you, Mark.
Tell us who you are before you ask a question.
Okay, my name is Elise Maybe. I'm with Patients Canada, and my question to you is, what role do you see for patients and citizens in affecting healthcare change?
Well, I guess I'd love them to be doing two things. One is to be demanding and sophisticated consumers. Like, I believe, that my colleague and friend Mike Porter was right in 1990 when he wrote the Competitive Advantage of Nations book and said, you can't be any good at anything. You can't be a good supplier to consumers of anything if they're not demanding and sophisticated. If they're not demanding or unsophisticated, they won't drive you to be better. So I'd like them to be demanding and sophisticated, not just demanding.
So we'll have one more question, and after that, feel free to scrum our guests at
they'll
the
get
front.
crap.
We always
but
do,
if they're
so
demanding
ready
and sophisticated, i.e., they will reward you.
That last
for
comment was a bit of a canary in the coal mine.
But the other thing is I would wish that they would be in some sense more holistic citizens. They vote for and support the fact that the primacy of Canada having this kind of healthcare system for all, without, I think, often taking any responsibility for making it work. So, I mean, I guess I would be hoping that they would be interested in how much it's costing for them to be doing what they're doing, and I think Canadians, it's just hard for them to be always aware. How much is this costing, and am I making this cost more than it would need to cost by my behavior? So I would want them to be demanding and sophisticated on one hand and stewards on another hand. Now, to show greater stewardship, I think we got to tell them the costs. I mean, I honestly think that you should be told what the cost is of everything every service that you get. Right? When you go to the emergency room for a cough, you should be told, oh, okay, that was whatever, $6,000 or whatever it was, because I think a lot of Canadians would say, well, seriously? I mean, I didn't mean to do that, but right now they have no idea. They're blissfully ignorant of that. We don't help them. So I'd want to help them more and have them get a little to be told, here's how much, here's the cost of what you just had done. And if it's a cancer treatment because you're going to die if you didn't get it, then you'd say, well, that's totally appropriate. That is good stewardship. That's taking care of yourself and trying to live as long as you can. But if it's something that's a little more frivolous, then I'd rather have you know.
So, Roger, the bad news is we're going to take one more question,
okay.
And it's going to come from way at the back.
All right.
Hi, Roger. I'm Candace Chartier with the Ontario Long-Term Care Association. 2 years ago, we released our expert panel report, Why Not Now?, which aligns quite nicely with Samir Sinha's senior care strategy. We've done a lot of work on the innovation piece with that report, and we have quite the footprint across the province, being in 634 communities. However, our profile has changed, and you touched on the mental health piece. We're now looking after 70% dementia or Alzheimer's clients, and mental health disorders are increasing at alarming rates.
70% of your clients are mental health or dementia?
Yes.
Wow, okay.
And about 46% of those residents have some form of aggressive behavior. So we see seniors as being a huge part of the healthcare system going forward. We just released our NANOS report on public opinion, and almost 80% of Ontarians are concerned or touched by long-term care.
Yep.
So at a relatively cheap price of $158 per day, we're looking after clinically complex residents and patients that would normally be in a complex care setting. So where in these policy opportunities do you see long-term care, specifically because we've done the research over the past year and the numbers are alarming of what's coming down the pipeline 10 years from now as well as 20 years from now. But we're also one of the biggest contributors to the ER number that you have up there, almost a third of our residents. So we know, we've done the research of what is possible. We've laid the innovative piece with the Why Not Now expert panel report. We just need to work with everybody to align the resources, I'm not saying give us more, but align the resources across the sector to spend our money smarter. We're the most heavily regulated sector in healthcare, and that could work for us in a lot of ways. So I guess my question is, where do you see long-term care in those policy opportunities?
Well, this may or may not be the right way to think about it, but I think about it in terms of the very holistic, different approach to end of life. So even though in this case the end of life could be 20 years in that long-term care facility, I think it should be part that whole kind of aspect. Like to me. There are sort of, in my own mind, there are sort of three pieces. Because I mean, I'm thinking about this from the economics and prosperity of a nation or jurisdiction. In this case, Ontario, is that there's kiddies, and doing the best we can to give them a chance to be a productive person and human. So to cure, if they were born with a heart that's got a flaw, we fix it, and then they give them a chance to have a productive life. And then we have sort of this productive part of your life care, where what we're trying to do is ameliorate things that make your quality of life as you're a productive member, a working member of the society, ameliorate things that make that harder for you, fix things. You're in a traffic accident, we got to fix it so that you can get back to having the productive life you want to have. And then there's a whole other piece for when you've ceased to be for one reason or another, often nothing to do with yourself, and how we should think holistically about that. So I would have those three big buckets and say we need to optimize the system for those three buckets, and the optimal system would look, I think, very different for each of those three buckets. And so I would put it in that big bucket, not as something that's separate from end of life. It would be in that third bucket. That may be a dumb idea for all I know, but that's the way. That's the answer to your question. What do you think, Anton?
Roger,
are we done here?
Your time's up. That's it.
Excellent. Thank you.
Now, if you want to learn more about some of the thinking that comes out of this wonderful resource we have sitting here, this must be one of your books, I presume.
One of my 8 books, if you can believe it.
One of 8 books. Playing to Win. I've looked through it, and it's a wonderful, some very good advice in thinking about that. And I'm going to give Roger a book that many of you maybe have already read from G. Ross Baker, and that's an analysis of systems around the world.
Yeah, Ross is awesome. I haven't read it, so I love it. Thank you. Thank you very much. Right. Thank you. Oh, whoa! Thank you. Thank you. Thank you.
I just want to say thank you for everyone for coming. A couple of things. So first of all, thank you for Roger for volunteering me for the OMA negotiation table. As my former colleague Shelley Jameson would know, I would love to sit at that table, so please welcome. Secondly, as always in healthcare, there are no shortage of problems. Please recognize that this is a working paper, and if you do have input to us on how we might tackle some of these problems or more problems to tackle, we look forward to doing so. And second and lastly, as Roger said, we have 2 more papers likely coming out within this fiscal year. One, we are going to look at the issue of healthcare as an economic driver, beyond just the most recent medical tourism spat. But if you're spending this much money, you should get some GDP growth for it. And then lastly, the report that will fix all of healthcare. We look forward to trying to tackle that. So thank you so much for this morning. All the best.